Will be entitled Doctors, Does Optimal Coherence Tomography Optimize Results After Stenting? Presenter will be Professor Nicolas Meneveau.
Thank you, Mr. Chairman. Ladies and gentlemen. These are my disclosures. Optical coherence tomography is frequently used on top of angiography to identify plaque morphologies in acute coronary syndrome patients, and sometimes as well to assess post-procedural results with a view to further optimizing outcomes. We know from the Illumian registry that OCT imaging during PCI impacts on physician decision-making in approximately 2/3 of cases. Whether this additional intervention prompted by OCT finding will translate into a clinical benefit or into a benefit in procedural outcome remains to be investigated. And so far, there is no randomized trial investigating the utility of OCT on top of angiography for the guidance of percutaneous coronary intervention, and more specifically in patients with non-acute coronary syndrome. Doctor study was a randomized prospective multicenter open-label trial conducted in 9 French hospitals, and the aim of the study was to evaluate whether the use of OCT during PCI would impact on the functional results of angioplasty as assessed by fractional flow reserve measured after stent implantation in a lesion responsible for non-ST elevation acute coronary syndrome. This is the flow chart of the study. Patients were randomized in 2 groups. In the angiography-guided group, the angioplasty was guided by fluoroscopy alone according to standard of care. In the OCT-guided group, OCT run was performed before and after stent implantation, and several OCT runs could then be performed accordingly. Before PCI, the operator was required to evaluate quantitative OCT measures, plaque morphology, presence and extent of thrombus or calcification, and the length of the stent and the diameter stent were to be chosen based on quantitative OCT measures. After stent implantation, again, operators was required to evaluate quantitative OCT measures as well as presence of thrombus, edge dissection, tissue prolapse, optimal lesion coverage, stent malapposition or under expansion, and consequently additional balloon overdilatation or additional stent implantation were to be performed in case of stent under expansion or incomplete lesion coverage. The fractional flow reserve was significantly improved in the OCT-guided group with a significantly higher value. The fractional flow reserve was measured at 0.92 in the angiography-guided group and 0.94 in the OCT-guided group. The OCT findings led to procedural optimization in approximately 50% of patients in the OCT-guided group. And as a result, the proportion of patients with post-PCI fractional flow reserve greater than 0.90 was increased by 22%. The improved result in the OCT group was, as you can see here, mainly driven by optimization in stent expansion. There was a significant increase in stent expansion from 78.9% immediately after stent implantation to 84.1% after post-optimization as assessed by OCT in the OCT-guided group. This improvement was obtained at the cost of a longer procedure with greater use of contrast medium, greater fluoroscopy time, and higher irradiation exposure, but without a higher rate of peri-procedural MI or acute kidney injury. So in conclusion, Doctors is the first randomized trial to investigate the use of OCT on top of the angiographic guidance in patients with acute coronary syndrome submitted to PCI. OCT provided useful information on top of that obtained by angiography alone, and this additional information led to a change in procedural strategy in 50% of cases and was associated with higher fractional flow reserve at the end of the procedure. The improvement, as you see, was driven mainly by optimization of stent expansion. The benefit was obtained at the cost of a longer procedure, longer fluoroscopy time, and more volume contrast medium, but without any increase in periprocedural MI or kidney dysfunction. Additional prospective studies with clinical endpoint are required before considering incorporating OCT guidance for standard use in patients with acute coronary syndrome. Thank you.
Thank you very much, Nicolas. I'll take questions from the press to Professor Meneveau. Yes, please, second row here.
Hi, I'm Nicola with MedPage Today. I'm just wondering if, in a way, this is a negative trial because OCT didn't improve outcomes, really.
Well, it's not a negative trial. It's clearly not a negative trial. I mean, the primary endpoint was the functional results at the end of the procedure as assessed by fractional flow reserve, and the difference was highly significant, statistically significant, even if the difference in absolute value was only 0.02 units. What we have to keep in mind is that the proportion of patients with post-PCI fractional flow reserve greater than 0.90 was increased by 22% in the OCT-guided group. And again, according to the primary endpoint, the study was positive.
So, as I understand it, the FFR value improved, but there was no link to a clear clinical benefit still?
No. We need additional data. We need additional study with clinical endpoints, of course, before considering incorporating OCT as a standard use in acute coronary syndrome patients. But we'll see that this is probably the first step. This is the first randomized trial showing potential positive effect on fractional flow reserve on the result of PCI in acute coronary syndrome patients.
Thank you.
Just another question there in the third row.
Hi, Sue Hughes from Medscape. Can you explain what this difference in fractional flow reserve actually means clinically? Is it a well-known surrogate endpoint that translates into clinical benefit?
Well, the higher the FFR, the lower the event rate. That's something that has been previously reported in many prospective and randomized trials. So we should consider FFR in the doctor study as a surrogate endpoint indeed.
And in patients having the OCT, do they also have normal angiography?
Sorry?
Is the OCT done in addition or instead of?
No, in addition.
In addition.
On top of.
On top
OCT
of.
was performed on top of angiography.
Okay.
Okay?
Okay, thank you. Any further question? Yes, please. You have a microphone, super.
Just very briefly, Shelley Wood with TCTMD again. Is an absolute difference in FFR of 0.02, can you tell me whether that's worth an increase in radiation and contrast dose? I mean, just trying to see the risk-benefit of such a small amount.
Well, you mean that the OCT procedure required to flush the coronary artery with more contrast medium. That's why we observed such an increase in the volume of contrast medium in the OCT-guided group. But in view of the study design, it's likely that there is potential to reduce the number of OCT runs and therefore the volume of contrast medium and the radiation exposure. But this has to be, yes, this has to be assessed in another clinical study.
But the degree of FFR value gained would be worth that additional risk?
Yeah. Well, I don't know.
Okay.
Yes, please, first row.
Mitchell Zola, Cardiology News. Could you be a little descriptive in terms of the kind of information that OCT provides and what you think is responsible for the better
Improvement.
the improvement in the PCI procedure compared to angiography alone?
Well, interestingly, the pre-PCI OCT run did not really change the procedural strategy, except for more frequent use of 2B3A inhibitors due to the higher rate of thrombus visualized by OCT. Conversely, the post-PCI run of OCT was very informative regarding stent under expansion, stent malapposition, or incomplete lesion coverage. So that's probably the most important point that are responsible for this improvement observed in fractional flow reserve. The improvement in the optimization in the stent expansion.
Optimization,
Yes.
Okay, thank you. Any further question? If this is not the case,